I am thrilled to be able to present or to introduce our presenters today. I have worked with them in multiple capacities, both with the DISC and with the San Diego HIV Implementation Science Hub. Um, Dr. Borsika Rabin is a professor at the UC San Diego Herbert Wertheim School of Public Health and Human Longevity Science and the co-director of the UC San Diego Dissemination and Implementation Science Center. She is an implementation scientist and public health researcher, and her research focuses on improving population health outcomes in clinical and public health settings through co-creation with partners with the intent to increase the equitable reach, adoption, implementation, and sustained use of evidence-based interventions. Through her career, she developed and implemented novel capacity building approaches for implementation science, including the D&I Models in Health Webtool. And she serves as the co-director for the Accords D&I Science Certificate Program at the University of Colorado. Dr. Laramie Smith is a professor in the Division of Infectious Diseases and Global Public Health. She has over 20 years of experience in collaborative research with public health and community partners. She's a social psychologist. She applies social and behavioral theory from a public health perspective to work towards solutions to syndemic upstream social and structural drivers that intersect in the HIV and opioid epidemics to produce worse outcomes in medically marginalized communities. For example, intersectional stigma, violence, resource insecurity. She is skilled in intervention and implementation science approaches using advanced quantitative, qualitative, and mixed methods to develop and evaluate HIV prevention and treatment strategies in clinical and community settings. Her work aims to advance tangible contributions to HIV science, policy, and praxis. Carrie Geremia is a project policy analyst 3 at the UC San Diego Herbert Wertheim School of Public Health and Human Longevity Science, and the program coordinator of the San Diego Implementation Science Hub. She brings over 20 years of experience in public health research, dissemination and implementation science, and research program management. Carrie manages a portfolio of implementation research projects, coordinating data collection and analysis, and coaching and webinar support for the Ending the HIV Epidemic initiatives. Her expertise spans qualitative and quantitative analyses, stakeholder engagement, knowledge translation, and staff mentorship. Carrie is passionate about strengthening research to practice impact and building capacity across academic and community partnerships. With that, I am going to hand it over to our presenters to get started.
Thank you so much, Kara. Very generous introductions. I am really honored to be co-presenting today with Dr. Smith and Carrie Geremia. We are working together very closely on a number of projects, as Kara suggested, and it's really lovely to talk about one of our shared projects, which is to bring HIV prevention and treatment-related concepts into the selection in theories, models, and frameworks in implementation science. So I will start by introducing you to the D&I Models web tool, which has been in existence for the past 11 years. And the acknowledgements are especially important in this context because what we present today is really the work of multiple groups. As you can see, University of Colorado, Denver, Washington University in St. Louis, and UC San Diego over the past decade to develop this tool. And more recently, through funding coming from our San Diego IS Hub, which Laramie, Carrie, and myself are very closely involved with, we were able to add these HIV relevant components. We wanted to make sure that those of you who come in here primarily from the HIV angle and have not seen the tool, you get to learn about all the different functionalities. Then I am going to hand this over to Carrie, who will describe the process that we undertook to develop this HIV component for the tool. And then Laramie is going to talk about specific example and guidance in thinking about selecting theories, models, and framework for implementation science work in the HIV space. So that's the agenda for today. And why don't we go to the next slide? So just kind of going back even one more step, when we think about the core elements of implementation science, I love this visual because it's pretty accessible and it shows those key things that we usually consider. So we are thinking about the evidence-based intervention or program. We are thinking about these implementation science theories, models, and frameworks. We are going to consider some strategies, implementation science strategies, and then some designs which will allow us to select also appropriate implementation science outcomes and measures. All of this is, of course, infused with engagement of various types of partners. Next slide. But as we think about today's presentation, we are really honing in this part that we often use theories, models, and frameworks throughout our implementation science projects as an underlying way of organizing our work. And so, go to the next slide, please. It's really important for us to have a good understanding what it takes to select an implementation theory, model, and framework. And often it can be actually a problem. So as you can see here, let's see, I'm sure your eyes are going toward the cow. So I would just say that we often teach courses about implementation science, introductory courses. And one of my students, Rachel Kenny from the VA in Denver, she was in one of my classes. And while we were discussing all these different theories, models, and frameworks and how you decide about them, she drew this visual on a paper and then sent it to us just to show that for her, it feels like, thinking about like a cow that you are kind of eating different grasses and you are deciding whether one is good or not. And then according to that, you are digesting them in a different ways. So I thought that that's very, very astute observation because we have approximately 200 theories, models, and framework in implementation science, which can be extremely overwhelming when you first encounter them. And so one of the most common questions that we receive as we work with individuals who are newer to the field is which TMF should I use? So let's go to the next slide. There are a number of tools, of course, that were developed to facilitate this process. And so let me show you a few of the other tools out there before I turn to the DNI Models web tool. There is a tool developed by Sarah Birkin and colleagues that is basically a comparison tool. So as you are identifying a number of different theories, models, and frameworks, it helps you look across them. So this is TCAST, and you can find it here and the publication. The next slide. Also, our colleagues, including Greg Ahrens, Nicole Stadnik, and others from UCSD and beyond, developed recommendations for how to use theories, models, and frameworks in implementation science. And this is critically important because selecting is one thing, but then how do you incorporate it meaningfully into your projects? So this publication and multiple checklists within it can be also a nice pragmatic tool to use. Next slide, please. And then finally, I will mention one more tool, although there are many other publications out there. It's a newer one, and this is published by Guillaume Fontaine and others from McGill and Canada. Overall, thinking about criteria again around selecting appropriate implementation science theories, models, and framework called Select It Meta Framework. And the next slide will give you a flavor of how they think about these 4 consecutive steps in making decisions about selections. And so we are actually working on incorporating some of the learnings from this new meta framework into the web tool that I am going to present to you now. But I recommend that you look up this paper. So the next slide will now take us to the web tool. So as I mentioned earlier, it's been 11 years actually that we have developed this. We have a couple of more recent publications, and there is one actually in the works describing the web tool, the history. So if you want to learn more, please access this. But let me show you the actual tool. And I would love for you to either raise your hands or put it in the chat. Have you ever heard about the DNI Models web tool? My Carrie goes to the next slide. Thank you. So the DNI Dissemination and Implementation Models in Health web tool is a publicly available tool that allows you to go through a multi-step process in selecting these TMFs, but then also using them. There are a number of steps, and we can go to the next slide. And these are plan, select, combine, adopt, use, and assess. I am not going to go through these. This is again just setting the stage for our today's presentation, but each step will provide you with guidance around planning. So here we talk about logic models, selecting. Here you can do that kind of search comparison work of identifying what theories, models, and frameworks might fit, and it could be multiple. If you chose multiple, guidance on how to combine those, adopt them to the given context, population, problem that you are dealing with, and then importantly use them. As I mentioned earlier, selecting is not enough. You have to actually incorporate them. And finally, to link them to assessment instruments. And so the little cheat here will be that I am going to tell you just a little bit about assess, because assess is an area that we are really focused on recently. We have just developed some more content here. So if Carrie goes to the next slide, I can show you that we incorporated here as a one-stop shop actual implementation science assessment instruments. And I'm not saying measures because we are actually brought here. We are including instruments that include quantitative approaches, qualitative, and then some that mix the two together. And you are able to search these across different criteria and identify ones that are most appropriate. The best linkage to the models is through these constructs. So we have this construct crosswalk, and if you know what construct you want to measure, you are able to actually identify assessment instruments that we have here. If we go to the next slide, when we launched the tool, we had 51 assessment instruments. Since then, thanks to primarily Kara's diligent work, we were able to increase that number to 75, I believe. And the nice thing about it is that you actually have the instruments directly accessible through the web tool, so you don't have to go out and look for them. We provide some characteristics of the instruments, which can allow you to search, make a decision if it would work for you. And these were the characteristics of the ones that we included in the initial launch time. We don't have the 75 characterized in the same beautiful visual. And then if we go to the next slide, I would just put out a call for action. We are in the process of further expanding the assess section, especially interested in expanding the HIV-IS intersection. And if you have any instruments, and again, it doesn't have to be in that HIV-IS, but if it's an IS instrument that you don't find here, or an instrument that you use often and you don't find here, we would greatly appreciate you sending it to us. You can use the QR code. There is a actual survey instrument that will come to Kara, who will be able to see these, and then our team can review them and potentially add them to the database. So that will end my presentation with the transition slide, which is the next slide. That today we really are talking about the special topics section of our web tool, which was another addition just over the past few years. The first special topic that we identified was health equity. And as you can tell, it's really an important topic because using theories, models, and framework in implementation science with a health equity lens is a critical question that we got very often. Since we are working in the HIV space more and more, especially through our HIV implementation science hubs, we felt that the second topic should be HIV and thinking about the unique considerations that you need to make to incorporate ISTMFs in HIV research. And so that's what this new special topic is about. And Carrie is going to tell you how we went about identifying content and good examples. And then again, Laramie will talk a little bit more about the content and guidance that we provided. Thank you so much.
Great, thanks, Borsika. Using Google Scholar and Web of Science and particular search terms that were related to HIV and implementation, prevention, treatment, and related services, we conducted a systematic review of studies published between 2020 and 2024. We focused our search on frameworks which are more commonly used, seen here in Tier 1, including CIFAR, REAIM, PRISM, EPIC, Paris, diffusion of innovation, normalization process theory, dynamic sustainability framework, and the theoretical domains framework. We also identified additional frameworks here in Tier 2, which have been related or used in related health equity work. Of our 2,300 articles screened, we found around 168, which were included in our analysis. Our original empirical studies were included if they satisfied these criteria. If they used the framework substantially to inform the design, data collection, evaluation, or analysis, and they addressed HIV prevention, intervention, or implementation. We excluded protocols, reviews, commentaries, and any studies that use the framework without a substantive application. We then abstracted these articles into a template. So we gathered the following information, which we have available now on the website, from study design information to where the study fell on HIV pillars, what kind of community partnerships the study involved, etc. From that process, we also identified studies that we saw using these frameworks in an exemplary way. So we identified case exemplars for the following frameworks. We found that these were ones that people could turn to as exemplary ways to use the frameworks in HIV research. And from there, then provided a more in-depth analysis of how that framework was used. So here you're seeing one of our case examples here, the branch study from 2020, which used REAIM substantively in their research. We provide for each of these case exemplars an overview of the study, all of the information that we collected on that abstraction template. And additionally, we analyzed this study's contributions to D&I science. So for each of our exemplars, one of these documents is available on the D&I Webtool. We also have some guidance about how to use these frameworks in HIV research, so I'll turn it over to Dr. Smith.
Thank you so much. And as we're coming into this section, I'm very mindful when I hear Borsika talk about folks who are newer to the field as a social psychologist, and then learning about implementation science. I still feel that, and am very appreciative of these opportunities to learn. So I just kind of want to get a sense from folks on the call here, how familiar are folks with HIV, the HIV research context, the HIV care continuum, or EHE pillars. So go ahead and just raise your hand or thumbs up in the chat, or thumbs up in the, if you're more familiar to that. Okay, so small amounts, some familiarity. Okay, all right. So that just helps me to guide the conversation around the guidance and how this tool can be applied, especially if you're thinking about moving more into implementation science in the context of HIV. So, and with the whole goal of these guidance to give clear, practical, insights into how you would apply these TMFs to the HIV research space. And so when we think about the HIV care continuum, it's kind of a continuum of engagement from screening for HIV through treatment, including engagement in both prevention services and programs as well, right? So it really integrates from prevention to care for folks living with HIV, as well as for those who may be more vulnerable to HIV through structural inequities, more integrating routine screening and reach of those evidence-based practices, including HIV testing and treatments to prevent HIV, such as PrEP or pre-exposure prophylaxis, doxypep, which can help prevent STIs, bacterial STIs, and harm reduction services such as syringe service exchange or overdose prevention such as naloxone. And then in terms of treatment, antiretroviral medications which can reduce the viral load and help someone to have a very healthy lifespan if they are living with HIV, right? So getting people engaged into these evidence-based treatments. And so if we can go into the next slide, I believe. I selected a couple of these guidances, but you can really use them to do a lot of what Borsika had talked about in terms of choosing having guidance on which kind of TMFs you might want to select, combine, or adapt. But when you're thinking about the HIV specific dimensions that you want to keep in mind to apply theory models and frameworks, it's important to think about where in the HIV care continuum you might be focusing on a specific component or linkages to those services. So do you want to increase HIV testing or access to harm reduction services, for example? Is your focus on getting people to start ART or maybe sustain and adhere to PrEP? Increase engagement in care for viral suppression monitoring or re-engaging people who have been lost to care. And then thinking about the ways that these different dimensions really overlap in terms of both sociostructural determinants and the priority populations, along with the types of service integration and delivery models you may want to focus in on. So for example, some of the sociostructural determinants that you might want to think about that may drive or affect the communities that you're working with are thinking about what types of specific stigmas related to individual health or social statuses folks might be contending with. For example, we have a study looking at an implementation of a stigma reduction intervention at both methadone clinics and in the communities, where we're having to very much attend to the ways that drug use, HIV, and drug treatment stigmas intersect and affect both how MMT staff engage with clients, as well as how people who use drugs in the community might engage in those evidence-based services and access or sustain their engagement in methadone, because methadone is a gold standard for reducing HIV risk and transmission among people with opioid use disorder. Thinking about service integration as well, specifically how services are not only just related for HIV, but also the related comorbidities. Oftentimes, HIV tends to be concentrated and disproportionately affect communities that experience intersecting health inequities as well. So in my example, there would be intersection of both HIV, hepatitis C, overdose, kind of comorbidities that we would want to think about in terms of service integration and how do we address those. And thinking about specifically the how those social and structural constructs amplify the vulnerability of the communities that you're working with that are most affected with HIV. And in particular, the equity and ethics of applying these processes and attending to how equity will be addressed in the implementation science process. So thinking through some things that Borsika had mentioned earlier about these more meaningful community engagement approaches, thinking through data sovereignty and data access. What does it mean to address confidentiality, build trust, and power sharing across those with those communities? So I'll ask for the next slide. Some of the other strategies and considerations that you might want to take into account when selecting theories, models, and frameworks for the HIV context is thinking about matching the scope of the question. So thinking about determinants frameworks such as CIFA or EPIS that may help to identify barriers and facilitators of implementation, all the way through to evaluation frameworks like REAIM or Proctor outcomes that can help you define and measure success, and context and equity attentive frameworks such as PRISM and to more intentionally offset those existing inequities that drive HIV transmission. And so, for example, in our HPTN 094 study, we use both REAIM, PRISM with REAIM outcomes to better understand factors in the community context, as well as mobile health delivery through mobile units, that context on how that would affect our REAIM outcomes for integrating HIV and medications for opioid use disorder for people who use drugs. You also want to think about where, again, in the continuing the HIV continuum you're focusing in on to make sure that the theories, models, and frameworks you select are most appropriate for that stage. So are you looking at a behavior such as PrEP persistence, or are you looking at something more around getting people in the door for ART initiation? And then thinking about the setting and scale, such as are you focusing on multi-site and scale-up of evidence-based interventions that might favor a theory, model, and framework with more strong context and sustainment constructs such as PRISM and EPIS, and also in relation to what we talked about previously, those community partnerships, if community engagement and leadership is central to that process, then selecting theories, models, and frameworks that pair more well with participatory approaches such as co-designing or CVPR approaches. And then next slide. So these are just some practical tips and common pitfalls, and I think that they relate to the HIV context as well as likely any other research context when you're thinking about the applications of theories, models, and frameworks. You do want to co-create a theory of change that ties how the theories and models and frameworks that you selected to the HIV care continuum stages. Are you focused more in on prevention? Or care, or both? Are you using a status neutral approach and thinking about how to move people in parallel through prevention and care continuums? You want to pre-specify the mechanisms that you're thinking about, such as thinking about reducing anticipated stigma in order to increase PrEP persistence, and then test them in relation to clinical outcomes. And then you may also want to think about mechanisms of your implementation strategies as well. I think there was a beachside chat on that the other day that really got me thinking a lot about that process. And you want to avoid, just like with any theory, you want to avoid name dropping without using them to inform your research aims, measures, and analysis. You really want to avoid ignoring the outer settings, such as policy, financing, supply chain, especially when you're thinking about scaling. But even in general, it's helpful to assess those factors as well. And then treating adaptations as ad hoc. This is one of the beautiful things about implementation science that really draws me to it, is that we know that adaptations will happen, and that can and will happen. So how do you think proactively about how to log those adaptations and think very mindfully about how they link to the outcomes throughout the process? And I would believe I pass this next one off to Borsika. Or is that one?
Thank you so much. Yes. So as you have seen, we have developed so far 2 topics: health equity, which we did not show today, but please go in and explore it, and the HIV topic. And the HIV topic, we are hoping to expand it further. But we are thinking about additional topics that might be cross-cutting and important to consider. So the ones that we have on our to-do list for the coming years is the implementation, dissemination as a cross-cutting topic, implementation science in aging, And then we would love any kind of other recommendations for additional topics that you might find helpful or important for your work. And with that, we actually are ready to open it up for conversation. We were hoping that this would be actually a longer time than usual, so you can all come off mute if you are in a good position, turn on your camera and join. If you are not able to do that, feel free to use the chat function. We will keep looking at the questions in the chat. We would love to hear. So let me start us off. We would love to hear about any experiences you have using implementation science theories, models, and framework in the context of HIV research or beyond. If you have any questions specific to the special topic or the tool in general, and then anything else beyond that is actually up for grabs. We are here to answer questions. And thank you so much for being here. So let's open it up for conversation.
Borsika, I am more than happy to kind of start us off. This is more of a question for all three of you, but as you guys were developing this special topic, was there anything that may have surprised you, either about HIV, the world of HIV and DNI, as you were coming up with the guidance and looking at these articles and coming up with the case examples? Was there anything that, kind of surprised you or that you found interesting to learn that you didn't know previously?
I will mention something, and then we'll hope that Laramie and Carrie, who were really deeply interacting with the case examples, can share some as well. From the perspective of just the big picture, comparing it to the health equity example, we found more good examples of TMF use, IS-TMF use in the HIV space than in the health equity space, which was very interesting to me. In fact, we were able to pick more TMFs to feature, and within each TMF, we picked often multiple case examples. Again, the case examples are good examples of use. We were trying to really pick the ones that we would want you to emulate and kind of look at and say. And so that was exciting to me because I know that HIV feels like came on to IS later than many other fields, but perhaps because of that, their use of IS TMFs is more mature, I would think. So that was one thing that I found interesting.
Yeah, I find that an interesting observation, Borsika, and I think that in the HIV context, I think it could be that it's the application of implementation science to HIV research has come on later in the field of implementation science, but most HIV researchers who are moving into and learning implementation science often come from a behavior change background. And so I think that in that sense, some of it feels very familiar, and that there's already been substantial training in how you utilize and apply theories and models and frameworks in your work, and that's something that is, I think, very 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 expected in the field. And so being able to access good theories, models, and frameworks and examples of them likely helped people apply them better. Even though it can very much appreciate the drawings that your student did with the cow and the grazing, because there are so many, and they do have a very different foci, right, in how they're utilized. So I'm glad that people were using them well.
Yeah, I was surprised to see when we compiled the data and looked at all of the articles that included these TMFs and HIV research that that second tier of frameworks that we looked at that were equity related were kind of underutilized, despite how relevant they are to this kind of work.
Mm-hmm.
And that these TMFs were not used across kind of more multiple stages of the implementation, that folks often focused on one stage and used the TMF there. So there's just a lot of room for growth and expansion of this work.
I would say when we're thinking about the different phases of implementation, that there's a lot of growth for that in the HIV space as well, right? I think that the funding and ability to focus more in on implementation science in HIV kind of nurtured the earlier, the development of these earlier implementation stages. And so I do think that there's a lot more room for growth in thinking about how do you expand that work and very consciously think about, more rich and robust understanding of implementation and the implementation process as well as sustainment and scale. I think that there's a lot of room for growth there for folks who are interested in those areas.
Great question, Kara. How about others? Any experiences or wonderings? Anyone who used the DNI web tool from this group or know about it? I didn't catch the responses when I asked about it. Not seeing anyone, so perhaps it's new to folks. Laramie, I had a question for you while others are thinking about questions. And again, please feel free to drop it in the chat or unmute as we'll keep asking you. But Laramie, I know that you ended up using the practical, robust implementation and sustainability model in your work in HIV in an unusual way, perhaps in a kind of more system level way. Would you mind to briefly talk about this? I know we didn't plan this, but I know that you have done this, so you know this well.
Yeah. Well, I think, we were looking at it, and this was for the HIV Prevention Trials Network 094 Protocol Integra. And Integra was, a hybrid type 1 trial where the primary emphasis was on the effectiveness of integrating evidence-based treatments for HIV, including both prevention medications, PrEP, and treatment medications, ART, as well as treatments for opioid use disorder, so buprenorphine. So delivering those integrated treatments through mobile units in local neighborhoods for people who inject drugs across 5 cities in the U.S. So we had Houston, Texas, Los Angeles, Philly, and Washington D.C. and New York City. So, and primarily in the Bronx in New York City. And so going into this RCT and knowing that the network was interested in understanding the implementation of this integrated care model, like just looking at it as, we knew that we were going to have very distinct geographies and socio-political contexts. Like our outer context of this RTC was going to be different. The shape of the neighborhoods, what it took to get into those different neighborhoods was going to be very different, right? And so we leveraged PRISM to help us understand those community contexts, those socio-political contexts, those geographic contexts kind of from early on, and specifically had the sites do these weekly ecological assessments where they were saying like what was going on in their the local implementation neighborhoods that they were in, and use that data to better understand those local contexts and how they affected site level implementation, as well as similarities and differences across the different sites. And so, and those data were really helpful in helping us to identify what made a good implementation site for rolling up with a mobile unit into people's neighborhood and being able to reach people, and what did not, right? And something that was very interesting is the differences in the substance use of the drug scenes across the different sites. where there were more kind of open air drug markets in places like the Bronx and Philadelphia, made it very easy to reach people. Whereas the difference in the drug use landscapes and the geographic spread in those places where people were using was so much different in Houston and on the West Coast, right? Because in Houston and LA were our sites out there where there was a lot more driving distance that's required to get around, but then also like trying to figure out where's those little pockets within those neighborhoods. So it's not like you can walk right up to it and you're like, oh, this is where we need to park the van. So much in the West Coast, because you might think that that's a good site, but you actually pull up to a site where like the substances that are being used are more, methamphetamine and alcohol, and not substances that are, align with the treatments that were being provided on the bus. So they ended up pairing with different kind of like I don't know the right term, because I wasn't prepared to talk about it, but like different systems in their local communities, right? Different response systems. So in LA, they ended up pairing with the housing response system, where they were setting these tiny home villages in LA, Project Room Key during COVID. So like where people were setting up housing support systems, when the van paired with them, was made it much easier to go and find pockets of people who would benefit from this intervention. Whereas in Houston, they actually had to pair with the fire department and their overdose response team. And that worked very well in Houston because of the relationship between the Houston Fire Department and the community. But pairing with those same systems in DC, which was undergoing rapid gentrification and disintegration of community trust, did not work, right? Like it did not work whatsoever. And so, it was, and it was, all of that was guided by like understanding how those different, those different constructs in PRISM, play together, right? That allowed us to capture that. Did I answer your question, or did I just go on a story?
No, this was great. Yeah, I was just thinking that that's a great example of using a TMF in a unique context, in some ways, in a very, very big context, multi-level context. Thank you so much. How about others? Any other questions you might have for us? Or related broadly on TMFs? Okay, I will have one more question. Could you put in the chat what TMFs are you using in your own work, implementation science theories, models, and frameworks? See a REAM coming through. How about others? And none is also a good answer. Prism and Apis. Very good. Okay, Prism, REAM, Apis. Very nice. Cipher and REAM. REAM, RF. Very nice. So very nice variety here. Any questions or challenges with deciding which one to use or using these frameworks? Laura says she used the Webtool. Thank you, Laura.
Borsika, related to that question, I find that on studies in which I'm not the lead, when I'm brought in as a co-investigator, sometimes the lead already has really kind of strong feelings or toward one framework over another. And I feel like I can maybe sway them if it's redundant or incompatible, but other times it's like, no, this is what we've always used. And even though it may not necessarily be like the framework that I would choose myself, I'm not sure if you've had those experiences or because of your work with Prism, Reaim, you feel very strongly that if you're involved in a project, you really could nudge them in that direction.
That is a super question. The kind of the answer that I would give is that in general, most of these frameworks, so I would say Prism, EPIS, CIFAR, and the number of others are very similar in that they are considering determinants. Many of them have either outcomes incorporated or you can pair it with an outcome framework. They are multi-level, they acknowledge multi-level factors, and they generally hit on similar constructs. So in, theory, you really cannot go wrong as long as these kind of features are present in a framework. Sometimes we want specialized frameworks, and that's fine. But these larger frameworks usually work similarly. There are some unique nuance differences. And then I would also say that it takes a moment to get used to them. So most of the work, as you suggested, Jessica, for me is happening with Prism or just the Reaim, depending on the project. And I am very comfortable using that and using them in a very creative way, thinking about innovation. When I use CIFAR, I am a little bit more I'm a little bit slower. I'm kind of more thoughtful, a little bit more to the point or to the letter of the law, basically, looking at their definitions because I don't use it as often. And the same with APIS, actually. I kind of think a little bit slower. I'm making sure that the way I conceptualize the different domains, they are correct, but I can do it. So there is an efficiency component of having someone on your team who is a good user of the framework because they can be much more comfortable, what adaptations are okay, what unique ways that you can use the framework. And that's what I would just consider with the investigator, that do they have that knowledge or do you have to build that knowledge within the team? Laramie?
I'm really glad that it comes up with a button in my face to tell me that I'm muted. I will say, as someone, and I was speaking earlier as a social psychologist trained in behavioral health theories, right? Like something that was very helpful for me to learn about the implementation science theories, frameworks, and models. That was different is that, like, if there is a construct, like you use that construct, right? Like, and it is fully defined and you apply it. And so then when I first went in to try and use CIFAR for the first time, it was like, how do I do all of this, right? Like, I was just like, oh, I was shaking a little, metaphorically and probably physically. Like, this is very comprehensive. So I think one of the things that along the way that has been very helpful is being thoughtful in the components of it that you are using. It is not like a social cognitive model where you can say, the information, motivation, behavioral skills produce the behavior change, but I'm really not interested in motivation, so I'll just ignore it, right? Like, like you get, like, it's different in that way. It's more like what is applicable to the work that you're doing, what is applicable to, like we were talking about with those guidance, to the context, to the ways that things are being delivered, to like how much is and to what degree is the outer context at play versus the inner context, and being thoughtful in what you how you pull from those things versus feeling like you have to address everything in it. And the same thing learning with Reaim, right? Like where at first I was like, there's this complex mental exercise where I'm like, okay, on this study, how am I going to like measure adoption? It's not really about adoption. I was like, okay, it's not really about adoption. So it's okay to acknowledge that, and the outcomes that I am measuring, making sure that I'm measuring them well and I'm understanding them well. That was very helpful for me. Oh, and now you are on mute, Borsika.
And I did not get a notification. I was just saying that these are really important observations the comprehensive use of frameworks and how feasible that is, the justification you might want to give, why certain things you include and not, and perhaps acknowledge them, but not necessarily act on everything. And then the idea, especially within REAIM, of which are the factors that are relevant
Mhm.
and which are the ones that you are not able to capture. I really love that. Wonderful. Well, we are getting to the top of the hour here, so I just wanted to say that I'm very grateful for the opportunity. And if you have any questions, please get in touch. Do send us your instruments if you want them to be featured or instruments that you feel like missing. And I will let Kara close us off.
Yeah, thank you, everyone. Please be sure to complete our brief evaluation survey. And we will see you in April. Thank you, everyone.
Thank you.
Bye.